An anterior approach to the cervical spine is one of the most commonly utilized by the spine surgeons. It is mostly done for anterior cervical decompression and fixation. And moreover, in those cases where we are doing fixation for 1 to 2 levels. If there is more than 2 levels and we need if there are more than 2 levels, then we prefer to go posterior. If there is kyphosis, we prefer to go anterior. If there is 1 to 2 levels, then we go anterior. So basically, I will first of all check the WHO checklist, intubate the patient, take a K-wire and check the level. While positioning, I would prefer to put a sandbag in the interscapular region. If the patient is a case of myelopathy, I prefer not to do it to avoid extension. I'll put the neck on the opposite side. Normally, we approach to the left side because right recurrent laryngeal nerve has some aberrant course, which makes things sometimes difficult. That's why I prefer to go lateral. Neck is in slight extension. So first of all, I give incision. My incision is transverse mostly, and it extends from the midline to the posterior border of sternocleidomastoid. I split platysma in the line of skin incision. It's supplied by facial nerve. I might ligate external jugular vein if needed. Transect cervical fascia anterior to the and parallel to the sternocleidomastoid muscle. Go down and then I will make an interval between the strap muscles and the sternocleidomastoid. Then I will reach a pretracheal fascia. I will incise the pretracheal fascia. At this level, I might need to ligate some branches of the superior and inferior thyroid arteries. Then I reach a carotid sheath, which should be retracted laterally, and the trachea and esophagus, which is retracted medially. Now I reach the prevertebral fascia. Over here, there are muscles called longus colli muscles. I need to be careful while retracting them because the sympathetic chain is just along the course of the longus colli muscles. I will subperiosteally elevate longus colli muscles. I will, if I'm doing cervical decompression at the lower level, that is C6, the carotid tubercle is one identification factor. I'll put my Casper pins and put Casper retractors. Give an incision at the level of disc after confirming that the image is fired with a K-wire. I will remove the disc, plate an appropriate cage, put an appropriate plate, remove the Casper pins, and close the wound. The problems in this surgery is, number one, most common problem is the recurrent laryngeal nerve injury. Recurrent laryngeal nerve injury will cause hoarseness of voice. I've seen cases where there are esophageal fistulas or tracheal fistulas have happened. Hematoma formation is a catastrophe in which the patient can go to a respiratory compromise. And there are other risks like failure of the surgery or a vascular injury in severe case, but it's quite rare. Regarding the complications of ACDF, first of all, the dissection is important. You can have bleeding from thyroid edema or thyroid arteries, superior and inferior thyroid arteries. You can injure the intercarotid sheath, causing a vessel injury. Then you reach longus colli and there are sympathetic chain which you can injure, which can cause Horner syndrome and other problems like respiratory compromise. Vital structures like trachea and esophagus around that area, which by doing forceful retraction can cause injury. and can cause fistula formation even. Then the hypoglossal nerve is nearby, which can be injured by the traction, and that could cause a problem in the muscles of the tongue. Then there are some important arteries like upper thoracervical arteries, which can get injured, and even stroke can happen and clot formation as well.